And we'll move into Dr. Shantanu Warhadpande. He is Clinical Assistant Professor, Radiology, Associate Director, and IR Medical Student Education at the University of Michigan. And he specializes in embolotherapy as well as pain interventions. He is the author and editor of the popular pocketbook of clinical IR for medical students. And at the University of Michigan, he is passionate about practicing VIR clinically and has a busy day of clinic every week. He is routinely found rounding on patients on the floor in ICUs and is proud to know many of the bedside nurses by their first names. His clinical passion is the management of BPH and the role of PAE, and he performs PAEs weekly and sees patients with BPH routinely in clinic.
So thanks for having me. Notice I titled my talk Benign Prostatic Hyperplasia, not PAE. That's by design. I think the theme of today has been learn the disease process, and I think that's super important. Just as an FYI, a lot of my patients that I'm seeing in clinic for BPH are self-referrals. So these are patients that sometimes have not seen a urologist. So you kind of need to know what urology does as well. So it's important to learn BPH management pre-procedure and almost think like a urologist does. So and I find that a lot of fun. Sinking your teeth into this disease process is critical if you want to play in the PAE world. So with that said, I have a lot of slides. I'm going to go through these quickly. I wish we had more time to really sink our teeth into the clinical workup. But before we talk about BPH, you got to learn about LUTS. So lower urinary tract symptoms in men, you have a whole set of symptoms. You can subdivide them into stored symptoms. So incomplete bladder emptying is sort of the main reason that happens, or voiding symptoms, an inability to create the pressure relate are needed to create a good stream. There's a host of reasons why a patient can have LUTS, and a big part of the pre-procedural workup is to make sure you're ruling out all of the other things that could be happening and isolating it to just BPH. So once you've done that, and I'll show you how we do that here, but once you do that, then you can proceed with consideration for a PAE. So BPH is super common. It's a fairly straightforward in the sense that it conceptually makes sense as to why it happens. As men get older, their prostate gets bigger. It's hormonally active, and as they see sort of a cumulative effect of testosterone over the years, the gland gets bigger. But it's benign. It's not cancerous. As the gland gets bigger, the resistance to urine flow gets more and more, and eventually they start having lower urinary tract symptoms. When I see my patients in clinic, I've worked this out with my NP. Before they even come to my clinic, there's two things that are sent to them: the IPSS questionnaire and the quality of life questionnaire. Both of these are already filled out. So before I even walk into the room, I already know what their symptom score is and what their quality of life symptom score is. My NP also tells them to have a bladder diary, which allows them to keep track of all their, every time they go to the bathroom, they make a note of it. So I can see that as well in clinic and say, okay, they're going 4 times a night, or they're able to go, a small amount in the morning or a small amount in the afternoon, and then a big void in the afternoon. So the bladder diary is really important. And again, as I mentioned, the whole point of this pre-procedural workup is to rule out all the other stuff that can cause LUTS and to make sure you're dealing with only BPH. And then the rest of the workup is again, fairly standard. I do like to get imaging. I usually like to get a prostate MR or a CTA, depending on which one they can tolerate. But knowing the size of the prostate is really important. And finally, urodynamic studies are really important. Sometimes they have them, sometimes they don't. I don't necessarily need them, but it's nice if they have them because it does give you a sense of sort of a quantification of how bad their LUTS is. You always start with medical management. I don't think there's a single patient that will not get this done before we even consider anything more invasive. So you always start off with an alpha blocker. Tamsulosin is sort of the big one that we've heard of. If that is not helping, you add dutasteride or finasteride. And then if the prostate size is a little bit larger, moderate or greater, so greater than 30 cc's, you start thinking about adding Cialis or a PDE5 inhibitor. So the main thing to remember about this is that it does help. These do absolutely help. But one of the consequences of these medications that they unfortunately do have sexual side effects, which a lot of men do not like. So I've done at least 3 patients in the last 4 months that I can think of that I've done the PAE specifically because yes, it's working. Yes, the meds are working, but they do not want the sexual side effects. So they want to get off of the drug. So my goal for these patients was to be able to wean them off the finasteride or whatever medication that they're on that is not working for them. You got to know the size of the prostate. So 30 and lower, this is why imaging is important, by the way. 30 and lower, small, moderate is 30 to 80, and then large is 80 and above. And the reason you need to know the size of the prostate is because that will inform what medications can and cannot work. So, for example, TURP is sort of your standard gold standard has been a gold standard for urology for a long time. You can't do a TURP in a large prostate. You have to do a HoLEP, which is a prostate size independent option. And then, of course, for large prostates, you have HoLEP and a simple prostatectomy. You have to know all of these. There's a lot of good data coming out on a lot of this. And they do work. They do absolutely help with the IPSS and quality of life. But if you, again, want to play in the PAE world, you have to know what the urologists are offering as well. And frankly, know what side effects there are, because some of these options are not available for patients who have, let's say, baseline sexual or ED, erectile dysfunction, or they're having issues with had the low libido or something like that. So you have to be aware of what the side effects of these are. And of course, now we can get into prostate artery embolization. So once you have worked your way all the way to this point, you've confirmed that it's BPH with your pre-procedural workup, you know exactly what size their prostate is. Now you can offer a PAE. So briefly, PAE was first described in 2000, and the initial, I would say, 5 to 10 years worth of studies were extremely controversial and contradictory, to be honest. So PAE did not gain as much traction as it probably could have. I think if we as a specialty had done a little bit of a better job in creating better research studies. However, in the last about 7-8 years, we do have very robust studies coming out with in reputable journals. So I'll show you guys those a couple of those articles, because I think it's worth looking into. And then finally, the big sort of boon and positive result of some of these more robust studies was that we finally made it into the AUA guidelines. So PAE, as of 2023, August 2023, is now part of the AUA guidelines, which is incredible. And there it is. So PAE, it's a same-day procedure. It's an outpatient procedure. Most of my patients go home the same day. You can do it with moderate sedation with a same-day return to ADLs, which is awesome. We have a very favorable side effect profile compared to a lot of the transurethral procedures when it comes to sexual dysfunction, and this is a huge deal for a lot of patients. And it does work, as I'll show you shortly. The disadvantages, it's really hard. It's a long procedure, a lot of radiation, and you need to be in a place that's doing a lot of them. I do not think you can dabble in this. I think you commit to it and you do a lot. So for example, I do probably, I would say 1 to 2 a week, and most of my clinic has, whether I like it or not, has become a lot of PAE. And I like it. I'm not saying I don't like it. I do love it. And then, of course, it doesn't happen overnight. The results of PAE do not happen overnight. It takes 8 to 12 weeks before you can see maximum benefit. So I'll show you a quick case to start off with. This is a patient who had a quality of life limiting hematuria. So this is a gentleman who had a coronary artery disease and a recent stenting on Plavix. BPH was, and BPH, IPSS was 18. He had a very complicated history, but the point was that he had hematuria. A lot of bleeding out of from his prostate. We confirmed it was from BPH and nothing else. This is just the coronal, or the axial and coronal CT. You can kind of make out the prostate here, and this is the coronal CT, and I'll point out right there in the center of the screen is hypervascular and bleeding median lobe. So we got into the right groin access, right internal iliac run shows this very faint artery going towards the midline pelvis. I always put a Foley balloon in with a little bit of contrast. So I have an angiographic landmark. This artery right here is cystic artery, and this artery right here is the prostatic artery. So we subselected that again, cystic artery, the vesicular artery, vesicular artery, and then the prostatic artery. You can see the prostatic blush there. Again, left side, same thing. Left internal iliac run shows a prostatic artery here. And then here's the prostatic blush on the left. We embolized with 300 to 500 micron particles. We restarted Plavix, given his CAD history and recent stenting on day 1. And he did awesome. 3 months later, I saw him in clinic. He had no episodes of hematuria. He owned a Mediterranean restaurant, so he got me a whole bunch of Mediterranean food, which was amazing. And his IPS has dropped from 18 to 8. I believe I've already gone through that. So I'm going to go through this really, really quickly. So brief literature review. We have a sham trial from 4 years ago that showed that PAE works. That, again, for sake of time, I'm going to kind of blow through this quickly. But the point is, it was a PAE versus sham, and the PAE results were excellent. And this is sort of the critical results that you need to see here. So patients who were randomized to a sham portion of the study, and then they were converted to the PAE arm, and you notice their IPSS dropped right when they got converted to the PAE arm. So, and then same thing for quality of life over here. So PAE worked. PAE absolutely worked in improving their symptoms. And then from there, we started having PAE versus TURP, which is sort of the gold standard for a urology perspective. And the same thing, it was what we kind of found. IPSS from baseline, big drop for PAE, big drop for TURP. So again, point being, PAE worked. Another trial, PAE versus TURP, and I'm showing you trials that are in big journals, and frankly, journals that urologists respect, which I think is important. We cannot keep publishing in our JVIR silo. We need to start publishing in other journals because that's what people see. That is our audience. So once again, same sort of theme that I was talking about. Mean reduction IPSS from baseline, TURP was awesome, PAE was awesome. It works. And most important thing that we keep saying over and over again is that the adverse events with PAEs is much lower than TURP. And this is another study, and this is sort of the critical kind of takeaway, which is that the summary of sort of a TLDR of the literature so far in the last 5-6 years, both TURP and PAE demonstrated an IPSS drop. The patients get better symptomatically. And the critical thing here is that it's for moderate and large prostates, not for small. Really, really important to remember. We do not have good data on small prostates. And frankly, I don't think, and I'll get to this, PAE should not be done for small prostates. TURP is just so much easier and better. TURP is way better when it comes to improvement in urodynamics. That's really important because you will have patients that you will see in clinic who have sequelae of chronic bladder outlet obstruction, things like stones, bladder stones, things like bladder diverticula, recurrent UTIs. Perhaps these are the patients that should not get PAE. Maybe they should get TURP. Again, you got to know your data. You got to know what works, what doesn't work, and you have to have no pride. If the patient is not going to improve from the PAE, send to urology, get a TURP. And then finally, as I mentioned, PAE is just better when it comes to side effects. So my personal takeaway is that PAE works. There is a significant reduction in IPSS and quality of life when done well. You got to do bilateral. I don't think unilateral works as well. It just doesn't. You got to do bilateral, and your embolization has to be thorough. I mean, you can't just be happy with one CCN and say that you're done. PA is very hard for small, but it's really, really easy for large prostates. So I'm going to show you one final case here and then be done. This was a gentleman, 78-year-old guy with acute urinary retention, had a large prostate, 364, had an indwelling Foley for 12 months. It was a hemophiliac. And you'll see the prostate jump out here. It's massive. Here's the prostate here, and same thing here. Massive prostate. So we got it, and you can even see the prostatic arteries on CTA very, very clearly. So the usual process, groin access, ipsilateral internal run, get the prostatic artery to show up, and then you have to do a cone beam CT. Really, really important to do a cone beam CT to make sure you're isolating the prostate from the bladder, from the rectum, from the penis. You have to do that. And then we did isolate on both sides the prostatic artery. This is our cone beam, intraprocedural cone beam CT. You can see the opacification of the hemiprostate on the right. Here's axial and coronal. Same thing on the other side. I use 3 to 500s to embolize. I don't like using 1 to 3s. I've had a couple not great side effects with 1 to 3, so I've pivoted to 3 to 5s. And here is the same procedure on the right side of the pelvis. And you see a beautiful blush of the hemiprostate on the right. Just in case, do another cone beam CT, confirm that you're getting only prostate and none of the other important things. I do not care about seminal vesicles. Those are almost always involved, and I really don't care. So with that said, we embolized. Patient did great. I saw him at the 1 month mark. Remember, he had an indwelling Foley. Big deal for him. That was the goal, was to get that Foley out. At the 3 month mark, we took the Foley out in clinic. He passed the voiding trials. PVR, post-void residual, was less than 50, which is great. And 10 months later, he continues to be catheter-free. His IPSS is negligible. So super, super happy. And this is sort of my final takeaway. we're going to be playing in this space. We are already in this space, and we have to be very, very good at BPH in the outpatient setting, pre and post procedure. In patients who have failed medical management, offer PAE as an adjunct to non-op management. Those words are important. Do not say they're competing with surgery. You have to offer it as an adjunct to non-op management. I think small prostate should get TURP, moderate to large PAE. And again, don't have pride. If you're seeing self referrals, if you feel like this is not going to work, refer to urology. Know your literature, and I think we'll be better informed as to who can best benefit from PAE.